Okay, we'll get going. All right, thank you and welcome everyone to the breakout session. I'm sorry that we got off to a little bit of a rocky start there, but thank you for bearing with us here. So this breakout session is about state flex program collaboration surrounding antimicrobial stewardship efforts across a couple of different state flex programs. So thank you so much for joining us. I'm going to help orient you here to the room and then introduce the learning objectives and our great speakers for this afternoon. So thank you again for being here. All these sessions are being recorded, and then the opportunity to play them back later on will be available within the attendee hub as well as on the task website. If you have any other technical difficulties, please utilize the chat feature, and Caleb and I from the National Rural Health Resource Center can help you out as we go through this here. We encourage your questions and interactions. So again, use the chat feature within Zoom here to send along any questions to the speakers, and Kayla and I can make sure that the speakers see those as well. You can also use the raise hand feature on your screen to kind of put a little icon up that you have a question, and we will get to you as soon as we can. We do ask that you keep your microphone muted if you're not speaking, but of course, when you do have a question to ask, please raise that hand and unmute your microphone. We'll make sure to call on you then. So the learning objectives for this session is that you, the participants, will be able to identify the potential of working with other state flex programs and similar projects with like vendors. So it may not be the same exact project, but the purpose here is to demonstrate how different states could come together, accomplish a similar type of project using a similar vendor. We'd also like you to be able to recognize how to leverage cross-state relationships for improved pricing, services, processes, and communication. So we have 4 speakers here today, and I'd like to introduce each of them to you. Stacie Rothwell is based in a frontier community in Eastern Oregon, and Stacie joined the Oregon Office of Rural Health in 2015. Stacie has over 16 years of healthcare administration experience, including working both in private and hospital-owned clinic administration, as well as being a member of a critical access hospital administrative team. Stacie has a combined 26 years of work experience in the healthcare industry, and she's the Oregon Office of Rural Health subject matter expert on hospital operations and quality improvement. Natalia Martinez-Paz is the program manager for the University of Washington's Tele-Antimicrobial Stewardship program, and she's been there since its program's inception in June of 2016. She has over 10 years of experience working in rural health and telehealth, having previously managed the University of Washington's Rural HIV telehealth program. Natalia has an MPA and an MA from the University of Washington and previously worked in international development in the southeast of Europe. Stephanie Sayegh joined the Idaho Bureau of Rural Health and Primary Care in 2011, and she's the Idaho Flex and Ship Program Manager. Stephanie provides technical assistance to the 27 Idaho critical access hospitals. Stephanie's a native Idahoan and spent many years working abroad. She was in the Peace Corps as a Peace Corps health volunteer in Honduras, and worked on a variety of education and health projects for non-governmental organizations in Sierra Leone and Mozambique. She received her BA from Boise State University in anthropology and Spanish, and her MA from the New School University in New York in international affairs and socioeconomic development. And then the 4th speaker today is Danielle Kunkel, and she currently holds the position of the Rural Hospital Quality Improvement Manager at Washington State Department of Health. Danielle coordinates and organizes technical assistance that benefits Washington's 39 critical access hospitals and the 5 rural hospitals, as well as serving as the MBQIP project coordinator for the state. Danielle completed her Master's of Public Health with Eastern Virginia Medical School, and she's currently completing her Doctorate of Health Sciences. She's earned her certificate in public health and in health education as a health education specialist as well. She spent 5 years in the public health field at the patient level before transitioning to the regulatory side. And Danielle is a Texas native, and she loves queso, the rodeo, and any dance floor. So with that, I will turn things over to our excellent presenters today. Thank you so much for being here.
Thank you so much. Give me a second just to pull up and share my slides and get these settled. All right. So thank you so much for that introduction. Again, my name is Natalia Martinez-Paz from the University of Washington. I'm going to talk quickly about our program and talk a little bit about the collaborations that made this happen, really, because it was certainly a collaboration between the Offices of Rural Health and the Washington State Department of Health that brought TASP into existence. I'm going to review our program and talk how we have managed it the last couple of years, and of course, COVID and what our network allowed us to do. And then I'll hand it over to my Flex colleagues. So the UW Task Program's mission is really to empower around education and build partnerships across the region, because we aim to build a community of learners around antimicrobial stewardship, AMS, infection prevention, infectious disease education, employee health, and anything related to that. And as we all know, these hospitals, and all hospitals, quite frankly, have a limited bandwidth, especially at the critical access level, and are resource limited. And there is no need to reinvent the wheel for things that have already been done. And so our goal is really to empower people through education and by providing resources to help do the work together as a community. We base our curriculum around the CDC core elements, around which I'm sure most of you are very familiar. And these are kind of the guiding principles for our presentations and our resources and our toolkits, which I'll touch on shortly. And as I'm also sure you all know, as of March 30th of last year, these became a required component of 4 critical access hospitals, of course, in the middle of the pandemic year. So that's our framework really for moving forward. And I'd like to just touch real quick about how TASK came to be. Because these core elements really, we knew that they were coming, we already had a strong stewardship program in Washington State. The Washington State Department of Health came together with Dr. John Lynch, our medical director, to think about how can we continue to empower sites and support them through their stewardship development and infection prevention and everything that comes along with that. So starting in 2016 in the summer, we started building the team, thinking about how the model was going to work for TASK, very closely with the Washington State Department of Health, who supported us both with curriculum development and partnerships and our community of network that we had, and also with seed funding at that time as well, to help build that out. And so we launched TASK in February of 2017, originally with 12 critical access hospitals just in Washington State, and had a 6-month pilot program to iron out where we would be at and if there was interest in kind of continuing that on. And there was. No sites dropped after 2017, after that 6-month pilot program. And what ended up happening is that over the next couple of years, we started mostly building out through word of mouth, through connections that we had, and ended up currently with about 33 critical access hospitals in Washington State and community hospitals. Through 2019, we also kind of started spilling over our borders a little bit, first into northern Idaho, partnering with the Northwest Hospital Consortium up there in the Panhandle, and with the Office of Rural Health. And the same with Oregon, partnering with Stacie's team at the Office of Rural Health in Oregon to help support critical access hospitals that were interested in joining TASK. And we also had our first TASK conference that year, which I'll touch on a little bit later. So partnering with the Offices of Rural Health and the Department of Health was really critical to us building out our program and to really getting buy-in, and also building a really strong program so that we could move forward. And I'm going to talk a little bit about our structure of TASK first, and then kind of go into where we're headed in the future. We base our curriculum and our policies around a toolkit, which really provides the policies, procedures, and protocols is how we call it. Because the reality is that people have already probably done what you're looking for, and if not, we'll build them together, because we want to be able to hand out concrete resources that you can take and make your own. And we want to move away from that traditional consult model of one person talking to one individual at a hospital, to a network of a community, and really becoming a regional team for antimicrobial stewardship, where it's the UW team as a component of that, but the stewardship teams at the hospital level are also that. And this is not a top-down information transfer. This is not the ivory tower telling people how to do things. That would be super inefficient and also not very helpful. We want to make sure that we're empowering the teams at the hospital level to share what they've already done, because the innovation happens at that level. And of course, to share that horizontally. So it's top down, it's bottom up, it's horizontal knowledge transfer. We want to make sure that we are building a cohesive team and that all of us are really part of that. So when we look at what the TASK community is, when I talk about what TASK is, it is not the University of Washington. It is all these hospitals coming together to build that community. Today, we are in 5 states, as I've mentioned, 6 actually. The orangey red are critical access hospitals in Washington State. The blue are community hospitals in Washington State. We have a handful of Oregon sites as well, with this dark purple. And then the lighter purple being in Idaho, both all the way up from the north, all the way down to the southeast corner. We are also in Maine, and this is part of where the word of mouth is important, actually, because this Maine site was originally a pharmacist who was the director of pharmacy in Port Angeles, Washington, moved to Maine and said, we could really benefit from TASP. I think we should join. He pitched it to his hospital, and now regular attendees from Maine are their ED physician, their director of pharmacy, and their infection preventionist sit in every single week. So we have that stewardship team joining us from there. And then we also have sites in southern Utah and also more recently in Arizona. So our model is, again, to empower through education and to help facilitate this work and learn from the community that we have and continue to build that. So if that sounds familiar, you're not wrong, because isn't that Project Echo? Meeting together, weekly sessions based around education. You're totally right that our roots are absolutely in Echo. But as I like to describe TASP, I like to call it Echo 2.0, because we move beyond kind of what the Echo model has laid out, which is those weekly sessions based around education, to build concrete tools, resources, and processes to help sites address their AMS needs. And I'm going to go through a couple of those examples. So I'm going to start with one, and all of this, just to be clear, we're learning from what sites need. So our goal is always to be responsive to what sites want. So in our site visits, we learned, hey, it would be really helpful to have a dashboard, because we have doctors who come in, they don't have the time to go through the website, they don't have the time to really sit down and give them an update as to what our projects are on, especially, you know, if you have your physician champion, but they're busy being doctors, like, do you have time to sit them down and walk them through what you're doing? So we built a dashboard, which is a PDSA cycle-based tool where you can go in and write out your projects so that providers and supporters across the hospital have a one-stop summary of what your projects are doing. So this is a project from Whidbey Health, which is in Whidbey Island, Washington, about what they're working on. They have a place for their description. They have their cycles where they go through their PDSA cycle. And you can see here, they're actually on cycle number 2 right now. They can also go back and take a look. Oh, they completed cycle 1 in 2019. And we saw, you know, what those project, what they set out to do and how, and what next steps were. So if you're a new provider coming in and you're trying to get caught up, or if you're just the physician champion, but you kind of want to get caught up because you haven't checked in a month, this is an easy way to be able to share where you're at on your specific projects in your hospital. It includes a project library, which are resources you can upload from the TASP website. We have a very extensive library of guidelines, resources, you know, things from the toolkits that I've mentioned, but you can also upload your own. So if you have your own questions, or not questions, but tracking tools that you use or internal reference points, you can put them in your project library to be able to reference and refer to later. We also ask that sites identify their core elements so that they are proactively thinking about how they're meeting those core elements as they go through their regular workflow. And this is just a snapshot of some of the sites that we have and what they're doing. And you can see there's a pretty big range. It's everything from general community education to antibiotic timeouts. And then they're tracking, you know, what they're doing. So if a hospital comes to me and say, hey, can you give me a report of what I'm, you know, a summary, like a 30,000 level view, I can send them, these are the elements that you're hitting, and this is how you're doing it. So that was one example. Another example we learned, or another issue we learned about, was that these hospitals are resource limited, as we all know. And sometimes you get locums who come in for a couple of weeks to do patient care and then leave. And then they may be coming from another part of the country that is very different. And so they're not familiar with regional prescribing guidance based off local resistance data. And so we created a pocket guide. And this is available to anybody if you go to our website, uwtasp.org. This antibiotic pocket guide is open source, relatively available, and it's a way to take a look at what are the most common things that we see and how do we prescribe with them. These are pulled from national guidelines, but they're adjusted for local resistance data. So currently it's based off the Pacific Northwest, Obviously, we've expanded beyond that at this point, so we'll have to adapt and give it an update. But this resource is something that people can use. It's a quick reference point. You can look at it online. And for our hospitals that are participating in our program, we actually mail them copies as well. So you can go and put one next to your computer and reference it there. It's designed to fit in a white coat, so you can carry it around in your pocket, so you always have it with you. As we talk about building on our network, one thing that we've also learned and want to highlight is the amazing work that's being done on the ground, right? Because the expertise is not always coming from UW, it's absolutely coming from our critical access hospitals and what they're already doing. So we had a very motivated infection preventionist, Barbara McDonald, who works with 4 different hospitals. And she decided, I want to look at what asymptomatic bacteria prescribing looks like in the hospitals I work with. So she collected that data and she presented it to TAS and said, this is what I saw, this is what I found. And we said, that's amazing. That's amazing work. How can we build on that and continue to just build on that and understand what's going on? And so our infectious disease pharmacist fellow took that and partnered with Barbara McDonald to create a collection tool and sent it out to the task network at large and had folks submit 1 month's worth of prescribing data to be able to look at what's going on in the community, and then presented this to the network. And now this fall, starting in September, we're taking this model and taking it on as a QI project, and then designing specific interventions around education for nursing prescribers, patient, pharmacy level, to look at what ASB prescribing data looks like once you have those interventions in place. So this was an example of something that amazing things that people are doing that we can build on and that we can use strategically at a regional level. Another example is just sharing what people are doing on a day-to-day level. So Lincoln Hospital in Washington State has an amazing director of pharmacy and who's really motivated. And she went through and presented how she tracks her AMS projects, how she designed her antibiogram. A lot of folks can't get antibiograms necessarily from their labs, so they have to create them themselves, which is very time intensive. So we asked them to highlight, what are you doing? Because we're probably doing something amazing, even if you don't know it. And that's an interesting thing that we've also learned, is that sites may feel like they're doing nothing, but by asking them to kind of give a review and update, they are already doing a lot. And it helps with morale, quite frankly, to realize that you're not behind, that you're not, coming in last with projects, because what you're already doing is probably addressing your core elements and your stewardship work. And it's just an issue of organizing and documenting it. And of course, having our conference. And again, we had our conference in 2019. We are tentatively planning for April 2022, which I'm thrilled about, to have everybody come back for a day of learning. We have amazing speakers, and then we have breakout sessions in the afternoon to specifically work on certain projects for hospitals. And so it's really important to get to know your teams. It's really important to understand the challenges they face. And this is one tool that we can do that. And, this goes into that handshake stewardship that at this point is probably elbow bumping, but, that's a really key piece that we're looking forward to having again next year. Offline, we've also done consults specifically on assessment tools. So we have sites fill out the CDC AMS assessment tool, and we go through point by point. Where are you at? How do you feel? What kind of support do you have? What do you feel like you need next? And we build out a plan that then they can put into the PDCA QI tracking tool to be able to expand on that and track it over time. So it's a lot of one-on-one. And that one-on-one, of course, goes in with site visits. And again, it's really important to get to know people, not just at the conference, but go and visit their communities. Who's your patient population? What's your catchment area? Where are you at in your site? Who's the key contact there? And really going to go visit them, understand where they're at, what their lives are like is very, very important. And again, something I'm really excited to start up again, since unfortunately those have been suspended due to COVID. So going back to both COVID and just partnerships in general, having expanded into Oregon and Idaho, having the conferences, working very closely with the offices of rural health, that was really key in making sure that we were able to then respond to COVID appropriately. So in 2020, we obviously have the final rule that was finalized for CMS, but COVID changed the way we do everything. And at that point, we had Arizona and Utah hospitals start to join. But I'm going to take a moment just to review how our COVID response played out. And the emphasis that it was because of our network that we were able to prepare. And it was because of our partnerships with the offices of rural health that we were able to spread our response as fast as quickly and share resources. So I'm sure, everybody knows we found COVID emerged rather in December of 2019 in Wuhan. And Washington State was the first place in the United States to have a confirmed case. Obviously, we knew now that it was in the community before that, but by January 21st, we knew that it was in Washington. We knew that we had no time to prepare, that we had to get a rapid response going, and we had to start communicating it to our rural communities that were going to be much more resource limited than academic medical centers where we were located. So on January 21st, we had our first COVID update to the task network. We started doing weekly updates thereafter, so super quickly. By February 26th, we had a home assessment workbook already done. So as I mentioned, Dr. John Lynch, he's the Director of Stewardship and Infection Prevention at UW. He's also the Director of the COVID response, and he is our medical director at TASC. So he was the first person really in the country to be doing home assessments, et cetera, all things like that, and pushing them out, getting them published as quick as possible. So we were able to push that out to our network saying, here are the pieces that you need in place as this emerges. PPE guidance, what do you need to have on hand? I distinctly remember him saying, you need to start counting your masks. How many masks do you have? You need to start reviewing your air system for engineering. By the 26th, we also had the UW Medicine COVID guidelines were up, which if you go now to the UW website, you can look at the portal. There's a COVID portal and click on that and you'll see the toolkit, which has a link to all UW resources, complete everything you need to know to deal with COVID in your hospital. And that open access website is freely available. It's not limited to test participants, and it's very prominently featured on our homepage. So as we look toward the spring of last year, it was a blessing and a curse that we got it right away in Washington State, because we had to come up with a response ASAP. We had no time to waste, which meant we had time to prepare our hospitals. And it wasn't that long, but we had about 3 months actually. And so we got right into PPE guidance. We got right into infection control, how to start screening your healthcare workers, how to start managing testing and treatment that was even possible. And we made these as open houses. So we had 2 sessions for COVID open houses that we told our contacts at the state level, so the Office of Rural Health, the Departments of Health, hey, send this out to everybody you know, and everybody is invited, because we just want to make sure that that information is out there in a timely manner. And then those were recorded and posted to our website with all the resources that folks needed. Last summer, community spread, reopening. Your hospitals have been closed since March. That's not sustainable. It's not sustainable for patient care, and it's not sustainable financially. And so what does reopening look like during community spread, and having guidelines for that and continuing to test and treat? For fall winter, last year we had the surges. We started, we had our second and third surges at that time. And what does testing continue to look like? What does infection prevention look like? And we got the glimmer of the end with vaccinations happening and healthcare worker vaccinations. In the winter and spring, then how does vaccine drives work? You have to continue to vaccinate your healthcare worker population, but a lot of these communities were tasked with vaccinating, or rather these hospitals were tasked with vaccinating their communities as well. And then looking forward, this is an endemic pandemic. So what does this look like? Because we're not done. And so going back to how we were able to leverage our task network really was pushing out information. As we all know, these sites are resource limited. People were tired before, people are exhausted now, but we had the time to rally them and to tell them that they needed to start to take this seriously and push out guidance super early. And the guidance was changing all the time. I'm sure you all remember that things were changing literally week to week. And so being able to have folks like Dr. Jill Lynch, who's on the board of the Infectious Disease Society of America, plus the entire UW ID team, put together guidelines and references and data, resources that are backed by data to push them out was invaluable. And we just had this network where we could push out information so fast. And that was really, really important, especially in an era of a lot of misinformation. And because we covered such a huge geographic area, it was almost like we had tiered responses. So we know it's in Washington, we know it's spreading here, we know it's going to hit here, we know in like a couple of months, Idaho is going to get their surge, and then it's going to go south, and it's going to go into Utah, and it's going to go into Oregon. And we had it. We were able to almost have like a tiered preparation level because of our just geographical spread, and that was really important because we, from the beginning, continued to press how important this was, and we leveraged our connections with the offices of rural health to remind folks, look, just start pushing this out, like who else needs the help, who else needs to get this information, and we can spread it as widely as we possibly can. And looking forward, this is the endemic pandemic, unfortunately. So we do have to get back to AMS. We do have to get back to the bread and butter of infectious diseases, and also manage COVID at the same time. So what does that look like? This is just a snapshot of a couple weeks old at this point of vaccination data for just our corner of the Northwest, which doesn't include the rest of our region. And where I live in Seattle, it's 84% vaccination rate in the city. But there are regions in Washington State, Idaho, Oregon, Utah, et cetera, Arizona, where vaccination rates are less than 30. So we're going to have pockets of this that are just going to continue to surge and strain our resources and strain our hospitals. And as we see here, this projection is out of date as well. But the Delta variant in the United States is now 90%, and in the Pacific Northwest it's at 60%, and it's more aggressive, and it looks like it's more, it's more communicable, but it looks like it's also just more deadly. So these hospitals are not going to be, unfortunately, getting relief anytime soon. And as long as we can leverage our network to help support them, we can build on that. But we're going to have to figure out what the new normal is, because the new normal is it's not going to be like the old one. So with that, I'm actually going to turn it over to Danielle in Washington, and I'll ask can somebody mute me, because I cannot mute myself now because I'm presenting.
Yeah, I can do that for you.
Great, thank you.
I will unmute Danielle.
Okay. Hi, Natalia, if you want to push forward to the Washington State slide. There we go. Hello, I'm Danielle. Usually, if you work with Washington a lot, my colleague even, she used to manage the TASK program when it first started. So you may recognize her, some of this information from way when she talked at the reverse site visit a few years ago. So we just wanted to highlight Washington State because the roots of the program started in our state and led to branches in other states, thanks to Natalia's work and dedication to the program. So just the place of the program, I wanted to talk about where we started. As Natalia mentioned, we started in January 2017, and we started with 12 critical access hospitals. And by the end of that year, we were able to add 5 more critical access hospitals plus 1 rural hospital. It started out small. We have 39 critical access hospitals in the state, but we continue to grow each year. So where we are now, about 4 years later, a little less than 4 years, we have 30 critical access hospitals participating and 29 critical access hospitals receiving flex funds to participate. 7 rural hospitals are participating, and we use SHIP funding for that program. We're hoping to go is use carrier funds for rural hospital participation whenever that is available. We're currently assisting critical access hospitals with transitioning to self-payment. Our goal right now, we do fund, as of 2020 and 2021, we did 529 of our critical access hospitals, and hoping to cut that down a little and start transitioning those critical access hospitals. Lastly, we wanted to talk about, we're now moving into participating in the multi-state UW Tele-Antibiotic program intensive activity for FY21. So this is the FORP required QI project. We'll be working with, it'll be a total of 5 states, so Oregon, Washington, Idaho, Arizona, and Utah. And we'll talk about that a little bit more as we move forward. Yeah, that's where we started, and that's where we're hoping to go. So I will pass it off to Stephanie, who can kind of continue this presentation.
Okay, can you guys still hear me? Hopefully.
Yes, we can, Stephanie.
Okay, good. Thanks. Okay, so I'm here to talk mostly about the collaboration aspect. So Washington, Oregon, and Idaho Flex coordinators got on a call with one another, and we started talking about UW-TASP and some of the opportunities. We also realized that there were healthcare associated infections programs in each of our states, and they were managing CDC grants. And the idea was to work together to try and braid the funding. So the HAI folks were going to ask for CDC funding for UW-TASP for hospitals, and the Flex coordinators were going to apply for funding for critical access hospitals. So we worked together so that even though the funding timelines were a little different, we wanted to follow sort of a similar approach. Unfortunately, the CDC funds were not awarded. In fact, they were actually cut for the states. And all of the Flex grants were awarded for what we'd asked for. And so we were able to leverage Flex funds to kind of really get this off the ground for the critical access hospitals. And Washington really led the charge. And since that time, since Idaho, Oregon, and Washington have collaborated, Arizona and Utah have gotten involved, and we've been working quite a bit together on the QI project. So it's been a really great opportunity to grow as a cross-state collaboration. Can you do the next slide? Thanks. So one of the things that was neat about trying to do this was figuring out how to really leverage and make this more accessible to the states and the hospitals. And so Washington, Oregon, and Idaho worked again with UW-TASP to create more of a subscription fee type structure that would allow more standardization across the states and really be more affordable for CAHs. They could kind of see how much it would cost if they were going to do a self-pay. Oregon really took the charge. Stacie Rothwell is amazing, and she created an application for the CAHs, and I replicated that in Idaho. And we require that the hospitals reapply each year. This really does help to ensure that there's engagement. With all the turnover, it's so much more difficult to try and make somebody participate if they're not in a place where they can do that, or they've lost like a pharmacist or something like that. Sometimes you just need to take a year off and then start again later, or leverage another funding source like SHIP at a different time. So within the application, only CAHs that actively report their annual facility survey information to NHSN or the National Healthcare Safety Network are able to apply. And that's just to kind of help keep them on track with MBQIP. We do give preference to those who demonstrate more team involvement and then that can consistently participate in the weekly sessions. So they can miss 2, but only 2 a month. And they're pretty good about communicating that. We created more of a point type system in the applications in case it is competitive. And you have them kind of give you an overview of their state, the state of their AMS program right now, their level of need, sort of future implementation or any outcomes they hope to achieve from it, and then their level of engagement or commitment. And ultimately, by doing this, they get access to the free, or they get free access to participate in the weekly UW-TASP sessions. They get access to the portal that houses a multitude of resources. They've got protocols, toolkits, things like that. And then they also get access to that team of infectious disease experts, which is really invaluable, especially for a lot of these smaller hospitals that don't have that infrastructure, to be able to ask questions to this group of folks and get really responsive answers. It's pretty amazing. It also gives their, that's not just for like one person, that's for anybody on the team that's participating from the critical access hospitals. And each of the sessions cover different topics each week. And the CAHs are invited to present cases for review with the panel of experts, which I think is really invaluable. If they don't have something to present, you know, it really just gives them an opportunity to learn from their peers. But I've been listening in whenever possible, and it's really neat to see some of our smaller hospitals, and they'll give, so kind of Catherine had asked the question, you know, is it more for a patient or is it for a provider? It really is for that team, but they can bring up specific cases of situations where maybe a patient didn't respond a certain way, or they were wondering, did they do the right thing? Did they think of everything that they could have thought of? And that's really what this is about. It gives them a platform to be able to do that. So that was what I wanted to say. And I will hand it over to Stacie.
Okay, thanks, Stephanie. One of the questions that I get when I'm talking to other state offices and sharing information about UW TASC is how we go about setting up our contracts to award the memberships to the critical access hospitals. And we've actually tried this a couple different ways over the years. Initially, we would go out to the critical access hospitals and solicit the memberships, award them, and then create a scope of work directly with the critical access hospital. We would pay the money to the critical access hospital directly for their membership. And from there, then the critical access hospital would have to engage with TASC, who also has a contracting process as well. And then they'd have to pay them and then get set up in the program. For some of our smaller independent hospitals, that worked out fine for them because they have small enough teams that they are able to, push the scope of work and the contract through and review them and get them approved pretty quickly. But we did find with some of our system-owned critical access hospitals that we started seeing a little bit of a bottleneck in that area. They often have their own legal teams or counsel on staff who obviously want to review all of those contracts and scopes of work. And so it just was an unnecessary delay, I guess you could say. So in more recent years, we transitioned over to a different system, and it's actually been working out pretty well. And it's where we create a scope of work and a contract directly with UW TASC. We pay them the total amount for however many memberships that we're awarding that year. And then we go out and solicit the cause and award the causes that are going to be members and hand them off to Natalia, who does an amazing job with her orientation process with them. And then Natalia already has that. She's building that relationship with them, and she can work with the hospital directly on that contracting piece. So this method seems to have just been a better streamlined and more efficient method overall as far as the contracting goes. But obviously it depends on the way your organization is structured and whatever works best for you, but that's what we've found in our experiences. So with the next slide, if you could move to the next one. So one of the things that we're finding year after year, especially after more hospitals are having memberships, is they're coming back to us because they want to renew. They're finding great value in the program, and they're asking if we have flex funds to be able to continue their membership. And sometimes we do, but not always. It doesn't always fit into our budget to be able to renew everybody's memberships. We always, in Oregon and all of the other states, we're consistently budgeting in memberships for the critical access hospitals, but we're also wanting to get new facilities who have not had a membership yet to join as well and be able to experience TASC. So what we've started to do is encourage them to utilize their SHIP dollars to continue their memberships. And that's been working out really well. In Oregon, we've got multiple hospitals who've started doing that regularly. And then we're also starting to see hospitals who just find so much value that they've added it as a line item within their annual budget. And so then they renew that way too. So that's been working out really well as well. On the next slide, I just wanted to share just a little bit about our QI cohort that we partnered with TASC on for fiscal year 21. And while this was a fairly easy decision to partner together with TASC among our 5 states, we did struggle a little bit at first when we were brainstorming on what we could use to measure change overall and see improvements. And since antibiotic stewardship is measured utilizing the annual facility survey, we were concerned that using the survey alone to measure change would just not align with our reporting deadlines. And plus, since the 7 core elements are measured, only once a year, that they wouldn't give us enough information throughout the year to measure actual progress during the cohort time period. So our states, we decided to utilize the data that we each had available to us through the Telegen and FMT reports. And first to identify each of our own individual states' lowest performing areas among the 7 core elements. And then once we did that, we compiled our states' findings together to see if we could identify 1 or 2 of the 7 core elements that we could focus on for the cohort as a whole. And so after we did that process, we were easily able to identify that both education and tracking were the lowest performing areas among all of our states. So when we shared that information with TASC, they confirmed that based on the data from their site visits and also the technical assistance that they had been providing to the cause, the education was definitely an area that they saw as a need as well. So that made it pretty easy for us to move forward and focus on education for our cohort topic. And so for the cohort, UW-TASC, and Natalia touched on this a little bit in her presentation as well, but they've created a practical framework to address antibiotic prescribing in asymptomatic bacteria, or ASB, which is the presence of bacteria in urine without evidence of infection. So their approach for the project is going to include both provider and patient education, as well as a playbook for tracking and monitoring data to evaluate process and clinical outcomes. And the critical access hospitals will monitor changes in prescribing practices and provide specific prescriber feedback throughout the project period. So that's kind of just like a high level overview of kind of what we're focusing on or chose to focus on for our QI project. We obviously have a lot of room to build stuff in, especially after our the presentation on Tuesday about the PDSA cycle and that type of stuff. But I feel like among our 5 states, we have a pretty solid plan moving forward, and we're excited to move forward with it. So on the last slide, it provides each of our contact information. And if anybody has any questions at all, please feel free to reach out to any of us. And it does have Natalia's website address that she was talking about earlier as well. So thank you, everybody.
Thank you, everyone. Do we have any questions for the group? We are just a bit over our scheduled time, but we started a little late, so I want to make sure we provide everyone ample opportunity for questions. There's been a conversation in the chat box, which is great. Thank you for that. Any questions for our presenters' discussion?
If you do think about it, reach out to your HAI coordinators if you haven't already in your states, because I actually got a call from one a couple of months ago, and she was going to reapply for the funding to try and help with UW-TASC and actually got awarded. So those relationships don't go away just because the funding cycle doesn't pan out the way you'd hope. And trying to braid those funds together has been my soapbox for a long time. So that was something I just found out about, and I'm really excited about trying to see how to boost resources and subscriptions so it's not just Flex, and then ideally have it work into their own budgets. I think is the big goal.
Awesome. Thank you, Stephanie. Thank you all of our speakers and presenters for taking the time and sharing your efforts with us. We will capture all of the stuff in the chat box and follow up with that stuff. We now have a break until 2:40. where we convene for a big plenary session again, focused on building a culture of ownership in a post-pandemic world with Joe Tai, values coach. Thanks, guys.
Thank you, guys.
Thank you.
Thank you. You guys did great. This was really beneficial. Thank you.
Oh, thanks, Kyle.
Thanks.